Welcome to another episode of the NEI podcast. It's day one of NEI Synapse, and we are here with Dr. Hu for an extended Q&A session. Let's listen in as she addresses your unanswered questions from today's presentation.
This is Dr. Rona Hu, and I'm doing a podcast today as my question and answer after two talks that I did this afternoon. The first one was on postpartum depression and, to a lesser extent, postpartum psychosis. And the second one was on an update on suicide prevention. So I will answer the questions that I received more or less in the order that I got them. So we'll be talking about postpartum depression first, and then about suicide prevention. So the first question that I got was, why lithium over atypical antipsychotics for women with previous postpartum psychosis? This is, I think, in response to a slide where it says, in women with previous postpartum psychosis, lithium should be initiated immediately after birth. And then as a subtext for that, it says, evidence also for antipsychotics and ECT. So the recommendation is based on several studies, Howard 2017, Meltzer-Brody 2015, these are all listed in the slide, Smith 2017, Tinkelman 2017, and based on there being more research at this time for lithium. Obviously, lithium is it's been around for a much longer time than the atypical antipsychotics. There is, I think, a growing body of evidence for atypical antipsychotics. So at this point, there is more research for lithium, but given that, you can also make the clinical judgment, especially based on a woman's history and whether she wants to breastfeed, that there are some studies, more studies all the time, on evidence for antipsychotics. Second question is, what's the prevalence of mood disorders or psychosis in women with PTSD postpartum? This is a great question, but I don't think we have studies for this, or I'm not aware of them. So this would almost be a good future NEI talk. Next question, how to discern postpartum OCD, obsessive compulsive disorder, from psychosis in terms of crazed fears of hurting the baby, etc. I would say that for this, it's similar to OCD versus psychosis in the non-postpartum woman. In general, OCD often has a more ego dystonicness to it. So, for example, people with feelings about washing or repetitive behaviors will say, this is crazy. I know I don't need to do this, but I can't help it. I feel like I have to. And with the obsessions as well, it's sort of like I have to count the number of letter A in this sentence when it doesn't make any sense. So in the postpartum mother, a postpartum mother with obsessive compulsive disorder might say, I keep thinking about hurting the baby, but I don't want to. A psychotic mother might say, I feel the baby's soul is at risk if I don't perform this purification ritual. And so ego syntonic versus ego dystonic can help you make that differentiation. It's a very good question. Next question, what do you know about refugees and postpartum depression? The person who wrote it said, the most severe cases I've seen have been in immigrant or refugee women. This is a great question, and I agree. In the talk itself, we talked about how women who have poor social support are at a higher risk for postpartum depression, and immigrant and refugee women have often left their entire social support system behind. They often don't speak the language in their new country. They often have left the home country for a variety of reasons that can include trauma, and of course refugee women by definition have had something traumatic happen. So if you're seeing women in your clinic that are pregnant or have just delivered and are from an immigrant refugee population, it behooves you to ask very sensitively and specifically about postpartum depression or postpartum psychosis. Next question is, do you view obsessive compulsive symptoms of the postpartum period as a common feature of postpartum depression or a separate OCD illness? This is sort of similar to the last one, except that this one is talking about OCD versus depression versus OCD versus psychosis. So I think there can be a lot of overlap. Whether it's separate, I think I've seen more of the overlapping postpartum depression with OCD rather than a completely separate OCD without depression. But there may be people who have more expertise in OCD who've seen more of the postpartum OCD without depression. Remember that since I've been medical director of an acute inpatient unit for 20 years, I think I'll probably see more hospitalization for depression than for obsessive compulsive disorder. Next question, what is the risk for Vibrid and breastfeeding? I don't think there's very much data out on that. What is your threshold for continuing to treat major depression with antidepressants during pregnancy based on growing evidence that each additional mood episode can have negative and long-lasting effects on both mom and baby? Yes, you do want to make sure that women are being treated adequately for major depression during pregnancy. And since this was an entirely separate talk, we didn't really go into treatment of mood disorders during pregnancy. That is a whole separate talk of at least 45 minutes, and we only had 45 minutes today to talk about postpartum treatment. So I think NEI always has something addressing one population or another. Maybe we can alternate every year to make sure that we talk about during pregnancy and then sometimes talking about postpartum. Kindly comment on the choice of antidepressant use in pregnancy. Again, this is very much a similar question to the last one, that we do want to talk about the use of antidepressants during pregnancy, and this is a separate topic, related but separate topic than postpartum. Here's an interesting question. What would be the first-line mood stabilizer in a lactating mother? So the most evidence at this point is for lithium. It does appear that lithium does cross into breast milk fairly easily, as does lamotrigine. And there's less of this with valproate, although it hasn't been as well studied. On the other hand, the antipsychotics, the atypical antipsychotics, appear to cross into breast milk much less. And so the ones that we specifically mentioned in the talk, lurasidone, quetiapine, asenapine, olanzapine, and ziprasidone, do have some good evidence on a favorable risk-benefit ratio. So lithium is better studied, but there is more on the atypical antipsychotics all the time. There's a, not question, but a specific ask that says, please educate on not using pregnancy categories as they are no longer acceptable to use. So yes, previously the ACOG, American College of Obstetrics and Gynecology, used category A, B, C, D, X. Now these have been replaced by sentences that are much more nuanced and using a discussion. So the letter grades were easy to use, but possibly misleading by being too simplistic. So I did, for example, mention that lurasidone at the time had received a category B rating. It does not necessarily mean that it is better than something that hasn't received a category B rating. So talking about the types of birth defects that have been found during which trimester, that's probably more nuanced and better for each woman than just having a blanket letter grade. Patients on maintenance atypical antipsychotics, thoughts on using it during the last trimester of pregnancy. Again, this wasn't a pregnancy talk. There are a lot of questions about pregnancy in our postpartum talk, but the evidence is clearly for using maintenance atypical antipsychotics. Patients who were already on atypical antipsychotics before they were pregnant should be continued on using it. You might change the ones depending on side effects and on various risk factors, but you should probably not stop an atypical antipsychotic during pregnancy on patients who were previously doing well on their atypical antipsychotics. Unfortunately, I've seen patients who have done this anyway, even against medical advice, and the results typically have not been good at all. If a patient undergoes an elective C-section, do the hormone levels drop the same way as they do during a vaginal delivery? This is a great question because, of course, you're not having the same sort of Pitocin shifts that you are during vaginal delivery, but remember that during the elective C-section, one of the key things that we emphasized is that the placenta leaves the woman's body, and the placenta was producing all this placental CRF, and so that feedback loop that helped stabilize the HPA axis during pregnancy is suddenly and very dramatically lost during delivery. So that will also be happening very quickly during the or just after the C-section. Here's a good question. Has brexanolone been trialed on patients with postpartum psychosis? Not that we know of. Any potential benefit? Gosh, it hasn't been tried yet. It is approved by the FDA now for postpartum depression, not for postpartum psychosis. It's much more difficult to do a study on postpartum psychosis. 1 or 2 cases per 1,000 versus 20% of women. That's just difficult to do, but I think that's a good question. Another good question, actually, they've all been really good questions. I wish I had answers for all of them, but here's one that I do have an answer for. What was the questionnaire for bipolar depression that was mentioned? It's not in the slides. Thank you. Yes, you're welcome. This was the MDQ, which is the Mood Disorders Questionnaire, and this was by Hirschfeld, Hirschfeld, first name R, I think Robert Hirschfeld, from 2000, American Journal of Psychiatry, and the notes that accompany the podcast will have the complete citation. So moving along to the questions about the second talk, an update on suicide prevention. This is a very good question. What are we missing in middle-aged white men with the highest suicide rate? How do we do better at catching risk in this population? I mentioned in the talk itself that 7 out of 10 suicides in the United States, completed suicides, are in white men. So what are we missing? So there are more whites, Caucasians, in the American population than other minority groups. But it's not just that. So, for example, women attempt more often than men do, but women complete less often. So what's happening here? Firearms are very much a part of it, and the American Foundation for Suicide Prevention has done an interesting map of suicide rates per capita, and the states that have the highest firearm possession have these very high suicide rates, places like Wyoming, Idaho. We also know that when people are able to screen for firearms, and the states that have firearms prohibitions do much better in terms of deaths by firearms. So that's something that the question is, how do we do better at catching risk in this population? Firearms are a very political issue, but working on getting firearms away from people who are at the highest suicide risk, this is something that I think we should all work together on. There's some other things that I guess have some political issues as well about despair in middle-aged white men, that a lot of the employment opportunities, a lot of the feeling of being needed or feeling like they're a burden, unemployment rates are very highly correlated with suicide rates in men, more than in women, I think. And so there's a lot of factors, not just one factor, in catching people before they attempt suicide, before they complete suicide. And we talked a lot about some of the other smaller risk factor groups, but I'm glad you brought up this particular group. How do you deal with a patient who looks better on the inpatient unit when assessing discharge readiness, as in, are they really ready to go home? This is something we struggle with all the time. This is something that we've been struggling with in the hospital, that you can ask about suicide risk, and you should, but this doesn't always guarantee that the patient really is ready. Pay attention to nonverbals. Talk with family. It's important before you discharge a patient to have a sort of what's analogous to the timeout in operating rooms. So it's standard now for people in operating rooms to do a quick timeout and just make sure that, this is the right patient, this is the right part of the body, and that everybody is ready to go ahead with the procedure. We standardly ask before a patient is about to be discharged, does anyone on the staff notice any risk factors that we haven't addressed? Does anyone have safety concerns? So that does help pick up nonverbal cues, something that maybe bugged somebody a little bit, but that they weren't sure if it met the threshold. So working together on an inpatient unit is key, making sure to get everybody together and be able to talk about each patient during rounds or in some sort of meeting where you get as many people as possible together, not just in the notes, and to work with the family if possible, make sure that they have some sort of follow-up. And none of this is foolproof, but it's still worth doing. Next question, would you include sustained harassment or bullying on a standardized risk assessment for adults? This is a great question because I think we're not doing enough of this. We know that depression associated with any sort of trauma probably doesn't respond very well to medication alone, that you need to do psychotherapy. And so as we talk about suicide, medications are helpful, but you probably also need to look at different types of trauma. And the idea that trauma is always a life-threatening experience, that's of course passé. We know that a lot of very severe trauma doesn't involve the physical risk of death, but shame, this feeling of being less than human, that is also very traumatic. In addition to harassment and bullying, I think that we probably don't screen enough for early childhood neglect. I had mentioned during the talk that I recently lost a patient to suicide, and something that has been bothering me for a while is the number of patients from immigrant populations who've been raised apart from their parents, probably sometimes sent back to the home country apart from the parents while the parents are trying to make a living in the United States or finishing their education, and sent to live often with a grandmother and then often for very long periods of time. So in the United States, non-immigrants, when they're busy, they may have family nearby that can help. For immigrants, there's often a reluctance to use someone outside the family, either for economic reasons or just that they don't trust someone outside of the family. They want their child to have the culture from the home origin. There's various things, but what they don't realize is how traumatic that it can be for a child to be away from the parents for this length of time without seeing their parents. I've been trying to address this with current immigrants who have sent their child back to the home country, and at least one of the patients said, oh, she got so upset when we tried to Skype her or FaceTime her that we've stopped doing that, with a toddler. And I just thought, this is something that, I said, no, please bring her back as soon as you can. So this is getting back to the previous question about postpartum depression and the probably increased risk in immigrant and refugee women. I think that suicide is probably at a higher rate. I don't know how well studied this is yet, but it's probably at a higher rate in people who suffered early childhood. Actually, I don't even want to call it neglect. Obviously, early childhood neglect is an issue, but I think a lot of parents that don't realize that when their child is raised by somebody else and then they're restored to their parents at grade school age as complete strangers to their parents, and especially when the person who's been raising them, say the grandmother in their home country, can't come to the United States with the child. I've had patients who were evaluated for autism. They were talking up a storm when they were in the home country and then come to the United States, and they're suddenly raised by complete strangers to them. And they don't realize that even though the parents have been thinking loving thoughts about them all this time, the child doesn't know that. And it's a risk factor that obviously in the adult patients that you have now, knowing about it, you could do more therapy around that and the mixed feelings around that and not medication alone. But I think if we can do some work around preventing these children of immigrants from being sent somewhere else for years during infancy and childhood, that would be something that hasn't been addressed adequately yet, but I think we could probably do a lot of good. I think that's the end of the questions that I received on the 2 talks this afternoon in postpartum. A lot of the questions were about pregnancy, but the talk about postpartum depression and in talking about suicide prevention, 2 separate talks, but with some overlap. And thank you for having so much patience. We got the questions and answers done in this podcast instead of right there in the lecture hall. And thank you all for your attention.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Synapse.